We're Team SCAX made up of Callum, Sean, Zara, Ada, and Kalele, and this is our presentation.
This is Faith, and compared to the average American, she can expect to die 20 years earlier. Her chances of dying in childbirth are 400 times higher. Her lifetime risk of catching tuberculosis or HIV is 5 times higher, and her chances of dying from COVID, 7 times as high. What has caused this inequity, you may ask? It all stems from colonization, where Western nations dominated countries and imposed their Eurocentric systems on the indigenous population. They brought European diseases, instigated class systems, and stole natural resources, which led to extreme socioeconomic deprivation, which is perpetuated today as inequities between those countries or populations and the colonial powers. Health equity benefits us all because when less people are sick, which results in an overall more productive society where we spend less on healthcare so that money can be invested elsewhere. Pandemics like COVID would not be as devastating because wide-scale vaccination would be easy and we could stop the spread of viruses in their tracks. But lack of healthcare infrastructure in the developing world is a huge barrier to this. So as a healthcare workforce, what can we do? Well, the main drivers of this inequity are actually outside the health system. Socioeconomic deprivation, climate change, infrastructure, the list goes on. But those with the power to do anything about these drivers are the ones who benefit most from the inequity, and they have no incentive to change this, which is why we as the healthcare workforce need to take actions into our hands and change what we can influence, which is the global healthcare system. Our intervention is to establish a global not-for-profit dedicated purely to reducing global health inequity. It will achieve this by targeting the cost of healthcare, the technology available, the supply of healthcare professionals, and geographical barriers to accessing healthcare.
One of the major drivers of inequity is the cost of healthcare, which makes it inaccessible to people in poorer countries where disposable income is lower. To address this, we would create a research and distribution arm of our organisation dedicated to reducing the cost of healthcare. Too long has the cost of healthcare been controlled by private profit-driven companies in the pharmaceutical industry. Research would focus on cost-saving measures like removing the need for the cold chain and reusable medical supplies. Distribution would focus on large-scale production of open access medicines and supplies to avoid patent infringement without price gouging. While this will take significant time, this advancement is necessary for improving access to healthcare. Another focus of our research arm would be reducing the burden of tropical disease. These diseases are not a priority for current pharmaceutical companies given the low revenue from selling pharmaceuticals to LICs. With the right amount of attention, these diseases could be eradicated, just like with so many other infectious diseases. Again, this will take time, but it is an important step in reducing the burden of disease. A major barrier to accessing healthcare in LICs is the physical location of the services. One reason for this is a lack of supply of healthcare professionals, meaning large cities are first priority and rural areas have a shortage of workers. This is driven by lower levels of education and brain drain from LICs to HICs. To address this, we would establish a global health education university targeted specifically at improving the supply of healthcare professionals in every discipline. The university will accept students from all across the globe with means-tested financial aid to encourage more applicants from poorer countries, which helps improve representation in the workforce. We will not limit the size of the course and use technology and remote learning to facilitate easy access. The curriculum will focus specifically on tropical and rural health to equip students with the best tools to work in LICs. Additionally, the students will be bonded to work in LICs and will only seek certification in those countries to prevent brain drain. This will take a long time, so in the short term, the organisations will focus on setting up medical professional working programs for practicing healthcare professionals and also students to support the functioning of the healthcare system.
Also, we realize worker supply is not the only issue affecting access and travel will still be required. Another goal of our not-for-profit would be to establish a world-renowned one-stop shop for evidence healthcare advice containing a mix of articles and videos translated into a range of languages. We will have chatbots which can engage with users and help direct them to relevant resources. We would eventually like to expand this to a global telehealth service where people who cannot access healthcare can have remote consultations with healthcare professionals from anywhere across the globe. Currently, there are major inequities in internet access. However, so these would need to be resolved before this solution is fully viable.
In conclusion, radical problems require radical solutions. We cannot rely on governments to dismantle hundreds of years of inequity in the making. We must take matters into our own hands, and together we can change the world. Thank you.